5 everyday medications that quietly raise heart risk. After 60, I want to start with a man I'll call Walter. 67, retired electrician, walked his dog 3 miles a day, rain or shine. His blood pressure was controlled, his labs were unremarkable, and his wife called him the healthiest stubborn man on the block. On an ordinary Thursday afternoon, Walter sat down at his kitchen table and never stood back up. A massive cardiac event, 11 days in the ICU, and a long, uncertain recovery. When his cardiologist went looking for a cause, the first question wasn't what disease was hiding in Walter's chest. It was, what was Walter taking every morning? Because Walter had been on 3 completely ordinary medications for years. Medications his body handled just fine when he first started them. Medications that had slowly, silently stopped being as safe as they once were. Walter's story isn't an outlier. It's playing out right now in millions of homes, where people are taking the exact same pills they were prescribed a decade ago, on the assumption that nothing about that equation has changed. That assumption is the problem. I'm Dr. Michael Carter, and today we're counting down 5 medications that, after age 60, have been linked to a quiet rise in heart attack and stroke risk. We're going from 5 to 1, and I'll tell you now. The medication at number 1 is not obscure. It's sitting in a huge number of medicine cabinets right now, taken every morning by people who believe, with total confidence, that it's protecting their heart. Before we get into it, where are you watching from, and how many medications are you currently on? Drop it in the comments. I read them, and they genuinely shape what we cover here. Why your body handles the same pill differently now. Here's the piece most doctors don't have time to walk you through in a rushed appointment, and once you understand it, the rest of this list makes complete sense. Your liver processes the majority of the drugs you take, breaking them down, converting them, clearing them out. After 60, blood flow to the liver drops by roughly 1/3 to nearly half compared to your younger years. That means a medication that used to clear your system efficiently now lingers considerably longer. The dose hasn't changed. The milligrams on the label haven't changed. But the effective dose your body is experiencing has quietly climbed. Your kidneys tell a similar story. Filtration rate declines measurably after 60, usually without any symptom announcing it. Waste products and drug byproducts that should be leaving on schedule start accumulating instead, staying in contact with your tissues longer than intended. Now layer your cardiovascular system on top of that. Arterial walls stiffen with age. The endothelium, the delicate inner lining of your blood vessels, becomes more fragile and less responsive. The balance between clotting and bleeding shifts. Put simply, your heart and vessels are operating with far less margin for error than they had at 45. So when a medication interacts with any of these systems, the effect isn't identical to what it used to be. It's amplified. A gentle nudge becomes a sustained push, applied daily for months or years. That's how silent cardiovascular risk accumulates. And here's the part that makes this genuinely tricky. None of it shows up as a symptom you'd think to mention at your next checkup. There's no warning light. Your labs can look completely normal while these changes are quietly reshaping how a familiar pill behaves inside you. That's exactly why this isn't something you can wait to notice. It has to be something you go looking for. With that in mind, let's start the countdown. Number 5. Decongestants, pseudoephedrine, and phenylephrine, the active ingredients in most cold, sinus, and allergy combination products. No prescription required, which is exactly why they fly under the radar. Their entire mechanism is vessel constriction. That's why your nose clears almost instantly. The swollen vessels inside your nasal passages tighten. But that constriction isn't limited to your sinuses. It spreads through your vascular system, your arms, your legs, your organs, and the vessels feeding your heart. In a body over 60, where the arteries are already stiffer and less elastic, that's mechanical tightening stacked on top of age-related tightening. Blood pressure climbs, heart rate rises, and your heart is pumping against noticeably more resistance than it's built for at this stage of life. Research published in the Archives of Internal Medicine found that adults over 60 taking pseudoephedrine-containing products experienced measurable blood pressure spikes that persisted for hours after a single dose. For anyone already managing hypertension, that temporary spike isn't temporary. It compounds every cold season, year after year. And most people taking a decongestant are also on a blood pressure medication, a pain reliever, or a sleep aid at the same time. That layering is a theme we'll keep returning to. Number 4. Benzodiazepines. Diazepam, lorazepam, alprazolam, and similar drugs prescribed for anxiety, insomnia, and nervous system calming. Millions of older adults rely on them nightly, not to get through a rough week, but because they feel like the only thing standing between them and a sleepless, anxious night. That relief is real, and I understand why people don't want to give it up. Here's what's happening underneath the calm. Benzodiazepines slow the central nervous system. That's the source of the relaxation. But they don't stop there. They slow breathing rate, dull muscle responsiveness, and reduce overall physical activity. After 60, your body becomes significantly more sensitive to all of this, not because you've gotten weaker, but because your liver clears the drug more slowly, letting it accumulate well beyond what was intended. The cardiovascular link rarely gets explained. Less movement means slower circulation, and blood pools more easily in the legs, quietly raising clot risk. Shallower breathing during sleep, a known effect of these drugs, means less oxygen reaching the heart muscle overnight. Night after night, your heart is working in a slightly oxygen-starved environment, while circulation is sluggish. A large study in the British Medical Journal found long-term benzodiazepine users faced a measurably elevated risk of cardiovascular events, with that risk climbing notably after continuous use past the 3-month mark. If this is landing for you, type 4 in the comments. It tells me you're still with me. Number 3. Proton pump inhibitors, PPIs. Omeprazole, esomeprazole, lansoprazole, the acid reducers prescribed for reflux, heartburn, ulcers, and often as stomach protection alongside other medications. They are staggeringly common. Tens of millions of people over 60 take one every morning, many for 5, 8, even 12 years straight. What rarely gets mentioned, stomach acid isn't just a source of discomfort. It's essential to how you absorb magnesium, calcium, and vitamin B12 from food. Suppress that acid for years, and those nutrients slowly get depleted. That's where the cardiovascular concern begins. Magnesium plays a direct role in keeping your heart's electrical rhythm stable. When levels drop below a critical threshold, that rhythm becomes vulnerable to arrhythmias, some harmless, some genuinely dangerous. A large study in JAMA Internal Medicine, tracking over 200,000 patients, found long-term PPI users had a significantly elevated heart attack risk compared to non-users, even after adjusting for other risk factors. Newer research also suggests PPIs may directly impair endothelial function, the same protective vessel lining we talked about earlier, weakening your cardiovascular defenses from the inside. An interruption. Eleanor's story. I want to pause here because this is the story that made me want to make this video. Eleanor was 71, sharp, independent, the kind of person who still managed her own finances and kept a garden the whole street admired. Over about 14 months, her son started noticing small changes. She was winded walking from the car into the grocery store. She was waking up dizzy most mornings. Her ankles were swelling by late afternoon, and twice in 1 month, her blood pressure at the pharmacy kiosk ran noticeably high. She assumed it was just age catching up. So did her son. Most of us would assume the same thing. But when Eleanor finally sat down with a physician who reviewed her full medication list, not just her symptoms, the picture changed. She'd been on a PPI for reflux for over 6 years. She was taking ibuprofen 3 or 4 times a week for knee pain, and every winter, she reached for an over-the-counter sinus medication with pseudoephedrine in it. 3 ordinary medications, each seemingly harmless alone. Together, in a 71-year-old body, they were pulling her cardiovascular system from 3 directions at once: fluid retention from the ibuprofen, nutrient depletion, and vessel stress from the PPI, blood pressure spikes from the decongestant. 4 months into a supervised medication review, her dizziness was gone, her swelling was gone, her blood pressure had stabilized. She told her son it felt like a weight had lifted off her chest that she hadn't even realized she was carrying. That's the entire point of this video. Now let's finish the countdown with the 2 most trusted, most common, and most rarely questioned medications on the list. Number 2, NSAIDs, ibuprofen, naproxen, and prescription-strength anti-inflammatories, used for joint pain, back pain, arthritis, and the general stiffness that becomes a familiar companion after 60. Because relief is fast and tangible, people rarely think twice about reaching for these regularly. Here's what's happening beyond the pain relief. NSAIDs block COX-1 and COX-2 enzymes to reduce inflammation. But those same enzymes help your blood vessels produce prostacyclin, a compound that keeps vessels relaxed and prevents platelets from clumping. Suppress that mechanism, and vessels gradually tighten while blood becomes slightly more prone to clotting. After 60, that effect lands on a system that's already stiffer and has less margin to spare. Blood pressure creeps up. Kidneys, already operating with reduced capacity, start retaining more sodium and fluid under the drug's influence. Now your heart is pushing against tighter vessels while managing a higher fluid load. A major meta-analysis in the BMJ, covering more than 350,000 patients, confirmed regular NSAID use was linked to a significantly higher risk of heart attack and stroke, with risk beginning to climb within the first week of consistent use. Number 1, low-dose aspirin. The pill I promised you at the start, baby aspirin, taken every morning by millions of people over 60 with total confidence that it's protecting their heart. For decades, it was considered one of the simplest, smartest habits in cardiovascular prevention. Your doctor recommended it, your father took it, it felt like common sense in tablet form. Here's what's changed. Aspirin works by making platelets less likely to clump and clot. In someone who's already had a heart attack or stroke, that anti-clotting effect provides real, measurable protection against a second event. That's established, and it still holds. But for people over 60 who've never had a cardiovascular event and are taking aspirin purely just in case, the math has shifted. Clotting isn't only a threat. It's also how your body seals damaged vessels and prevents bleeding. After 60, vessel walls grow more fragile, the stomach and intestinal lining thins, and the blood-brain barrier loses resilience. Suppress clotting in that context, and the risk of internal bleeding, gastrointestinal bleeding, and critically, hemorrhagic stroke rises meaningfully. The ASPRI trial, following more than 19,000 healthy adults over 65, found daily low-dose aspirin provided no significant cardiovascular benefit in that population, while producing a meaningfully higher rate of serious bleeding. The protection people believed they had simply wasn't showing up in the data. This is why the distinction matters so much. Aspirin for secondary prevention, after you've already had a heart attack, a stroke, or a stent placed, is a different conversation entirely, backed by decades of solid evidence. This isn't about that group. It's about the much larger group taking it purely as insurance with no prior event, on the assumption that more protection can only help. For that group specifically, the evidence has quietly moved in the opposite direction, and most people have never been told. What to actually do with this, I want to be very clear. Nothing here is telling you to stop a medication on your own. That has never been the message. The message is that your body has changed, and your medication list deserves to be re-examined in light of that. 1. Write down everything you take. Every prescription, every over-the-counter pill, every supplement, every just occasionally pain reliever or antacid, with dosages and how long you've been on each. This list is your most useful tool. 2. Book a dedicated medication review with your primary care physician. Use that phrase specifically. Ask for a review focused on cardiovascular risk and whether each drug still makes sense at your current age. 3. Ask 3 questions about every item on the list. Is this still necessary? Has my risk profile changed since it was first prescribed? Is there a safer alternative or lower dose that achieves the same result? 4. Ask specifically about interactions, not just between prescriptions, but between your prescriptions and your over-the-counter habits. Many pharmacists can run a full interaction screen in under 10 minutes. 5. Request baseline labs that include magnesium, kidney function, liver function, and inflammatory markers. These numbers reveal whether a medication is quietly depleting something your heart depends on. None of these 5 steps require a specialist or a complicated process. They require about 20 minutes of your time and a willingness to ask questions that might feel slightly uncomfortable to bring up. That discomfort is worth it. A good physician isn't going to be irritated by a patient who shows up organized and curious about their own care. If anything, it makes their job easier because it hands them exactly the information they need to make a good decision on your behalf. The countdown, one more time. 5. Decongestants, constricting vessels body-wide with no margin left to absorb the spike. 4. Benzodiazepines, slowing circulation and breathing while your heart works overnight in an oxygen-thin environment. 3. PPIs, quietly draining the minerals your heart's rhythm depends on. 2. NSAIDs, tightening vessels and retaining fluid your kidneys can no longer easily clear. 1. Low-dose aspirin, offering little benefit and real bleeding risk for people who've never had a cardiovascular event. None of these drugs are inherently dangerous. Every one of them has a legitimate purpose for the right person at the right time. But the context changes. Your body changes. And the most important thing you can do for your heart this year isn't adding something new. It's reevaluating what's already there. Walter didn't have to have that afternoon in his kitchen unfold the way it did. And your story doesn't have to either. You have something he didn't have that day. Awareness. And awareness, acted on, is the most powerful medicine you'll ever get without a prescription. If this was useful, a thumbs up helps it reach more people who need it. Subscribe if you're new, and tell me in the comments which of these 5 surprised you most. I read every one, and it shapes exactly what we cover next. Take care of yourselves. I'll see you in the next one.